it's an autoimmune disorder, and it's inflamed connective tissues. And what are synovial joints to you?
Small.
Yeah, they have like lubrication and all that. Yes. So it can be very severe or it can be very mild. So it is the most prevalent inflammatory arthritis of any age group. Osteoarthritis there can be inflammation associated with it, but it's not caused by inflammation. The inflammation comes after the joints start, or the bones start rubbing bone on bone instead of having the synovial fluid to lubricate and such. So it's not the most prevalent arthritis, it's the most prevalent inflammatory arthritis. So that's the key word, inflammatory. Okay. So the osteo is a degenerative. That's the degeneration is the cause of the inflammation. It's called autoimmunity, but the main symptom is inflammatory. Okay. So, and I think we kind of got that when we're talking about our hypersensitivity type 3, that it's overactive functioning of the immune system. It's hyper, exaggerated. And so it's attacking the body's own tissues. So I think we've got that pretty well established. We really don't know why it happens. It's a multifactorial thing, because it can be genetics, it can be environmental or hormonal, reproductive. Lots of things do come into play. But it is the genetic predisposition, though, is a major factor. It may not be the only cause, but it is a major factor there as far as being susceptible to it and how bad it is. So, and it is autoimmune, and it is a type 3 hypersensitivity reaction with those. You remember what a type 3 does? What's the characteristic of that one? Yeah, it's the complexes. It clumps up, doesn't it? It clumps up and it damages tissue, ends up damaging the tissue, bringing in all those inflammatory mediators, and then that they damage the tissue. So, I think we're already trying to not repeat all this stuff, because it's just giving you a little review there. But the risk factors. Women are between 40 and 60 years old are the largest group that gets the rheumatoid arthritis, and then the family history. And smokers, they're finding that smokers have a higher incidence. So don't know if it's the smoking that's doing that, or there's something in their body that makes them want to smoke that causes RA at the same time. I don't know. But anyway, the smokers do have a higher incidence of it. And women are affected about 3 times more than men are. So the onset is 40 to 60, and it has decreased, though, in the last 40 years. And that's kind of interesting. There's some diseases that are just really revving up with our lifestyles and environment and everything now. But this one has decreased somewhat. I don't really know. But it is definitely less common than the osteoarthritis, because everybody that gets old enough is going to wear out some things, and so those joints can be sort of creaking together. Have you heard the term crepitus? That's such an interesting word, isn't it? But it's a creaky sound. You can have crepitus like under the skin too, that makes sort of a popping sound, or like you've got an air leak in your chest. Then sometimes you can feel it's sort of like bubble wrap when you feel of it. We had a patient like that one time that was having respiratory issues, and you could feel the crepitus under the skin. But this crepitus means the creakiness and the scraping kind of sound and feeling that it makes. So you can have multiple joints that are inflamed, and a lot of deformity, or it could be very, very mild and just somewhat painful and aggravating, but not necessarily as bad as some of the pictures you're going to see, or if you've already read your chapter, you've seen a lot of those deformities already. It does contribute to disability and decrease this life expectancy. So it usually is symmetrical involvement of multiple joints, especially the peripheral joints that have the synovial fluid, even like your fingers. Because if you've seen those distorted pictures and everything, the fingers are really susceptible to that. And you can have remissions, but then you can have exacerbations too. And the exacerbations are often called flare-ups. So you may hear it called flare-ups instead of exacerbation. We hear that exacerbation word a lot in with COPD, don't we, as far as diagnoses in the hospital. But just it's kicking up really, really severely. Okay, so we've got a joint picture here. All right, the pannus area is the eroded. The pannus is growing, this sort of inflamed area, and it's starting to erode the cartilage in the bone. And it's increasing the joint fluid. You would think that you would like to have a lot of joint fluid, but you get too much, then it's I guess the body just recognizes that that's non-self if you've got too much fluid too, and that inflammation causes fluid and it causes discharge. That's one of the things that you will see with inflammation, and so it's sort of a vicious cycle there. And you've got the synovial membrane gets inflamed, making more and more fluid, and the inflammation is breaking down the bone tissue. And so it's a very difficult thing to have to live with, for sure. So there's some antigen or that the body is it's some kind of cell or protein that your body is recognizing as foreign, and we don't really know what that is. Sorry, sorry about that. Okay, and then what your normal antibodies become autoantibodies, and that's not a good thing. So transformed antibodies are called rheumatoid factors. So when they're doing the test for rheumatoid factor, that actually is an antibody that they're looking for. Of course, it's made of proteins, and you can test that with a blood sample. And the leukocytes are attracted to that synovial membrane, and if the synovial membrane is damaged, then there's hemorrhage, there's coagulation, there's fibrin deposits. What's fibrin do? Yeah, it has a part in clotting, doesn't it? So then it develops into granulation tissue, which is the pannus. Oh, you think granulation tissue is a great thing, isn't it? When we're talking about wound care and all of wound healing, but it's like creating a wound, and it's trying to heal it like you normally would, like with an incision or something. But it just causes more problems because it crowds up all of that stuff in the knee, and the inflammatory proteins are in there attacking the tissue. So it's just this kind of vicious cycle going on. And then the inflammation does lead to scar formation, and then that's what causes the immobility of the joint. So you don't have the same functional ability. Okay. This is really interesting. I always thought that rheumatoid arthritis was just, when you're saying R-A-R-T-H, that means you're in a joint. That's what the big is. But, so we talked about arthralgia yesterday, like that was a symptom. Yeah, and yet, but sometimes before you even have any of the dysfunction of the bones and the joints, some of the bones is the joint itself, the synovial joints, but sometimes the first sign of it is fatigue and malaise. Now, how vague is that? Who's not tired, and who never feels bad? I mean, like, you just feel iffy some days, and it's like, but if it's a continual and progressive fatigue, that could be the first symptom, and it could be one of the worst symptoms, because the usage of the joints and all is one thing, but if you're that tired all the time, and then of course if your joints aren't cooperating either, there's not a great quality of life or ability to like hold down a strenuous job, of course, and so the fatigue in some cases can be the very worst symptom in some people's situations. So fatigue and malaise really are one of the major symptoms, and that was a surprise to me. And you think that it would come like later instead of sooner, but sometimes that's the very first thing. So you can have loss of appetite and weight loss. Would you even think about that as a symptom of rheumatoid arthritis starting to kick up? I mean, that's a big deal. And then the morning stiffness lasts more than an hour, and it's significant and often disabling. Like you absolutely can't get up. I mean, it's not like, oh, I just feel kind of stiff. I did exercise last night, went to the gym, and I'm just sore, and I just don't feel like getting up, and I'll just lay in bed a while. No, this is I cannot get up. Absolutely cannot get up. And this is one of the when you have the mobility unit and she'll have a BB. I think it's time we teach that. She usually teaches that. She does a wonderful job of that. But she has it herself. This Rumble has the rheumatoid. This is one of the differentiations between rheumatoid arthritis and osteoarthritis is that usually morning stiffness with osteoarthritis is less than an hour. And so the more than an hour, kind of, that's the characteristic of rheumatoid. So, and then once you get going, most of the time, once that you get over that stiffness, then you're able to do some things during the day. So people can do better if once they do get up, and that would be more of a moderate kind of case. Some people can't use their joints at all, but then you guys have widespread muscle aches. That's the myalgias, right? We talked about yesterday, and then just weakness, just generalized weakness. So, you know, what's up? I know I'm getting into a NANDA thing here, and I keep saying I'm not going to just totally do that, but I think we have some good NANDA diagnoses here. But what's up if the patient is really fatigued and they can't use their joints well and all that? What's a nursing diagnosis that you could be seeing that's maybe one of those psychosocial ones, not necessarily that we're going to see pain and we're going to see some mobility issues and stuff like that. Mm-hmm. Yeah, it could be because you're not able to get up and go places. Yeah. What else? What's that? Yeah. Yes. Absolutely. Mm-hmm. Because you're used to going and.
What did she say?
Role performance. Yeah, and there's another one that's very similar to that. What were you going to say, Jennifer?
I said like altered mood, like relationship to depression.
Yeah, you can certainly, because that's a body image issue, isn't it? It's not just body. It's like, but it does involve the body, the deformities for one thing. But then what you can't do, what you're functioning, your body's not functioning the way that your brain's wanting to tell your body that you need to be doing this, and I need to do this, I need to do that, and I'm so tired I can't do it. And also I can't do it because I can't move my joints. And well, the one I was thinking of is home maintenance, but that's really role performance too, and a lot of those kind of merge together. But if you are trying to like get along in life and to have some quality of life, and we've got all this fatigue and everything. Like what if you get up in the morning? Okay, you have the stiffness and you can't get up until like an hour after you wake up, and then you sort of start moving and start doing some things, but like at 10 o'clock in the morning, you're just already just kind of just fizzled out. And so what are we going to do as nurses to deal with that, or help them deal with that? What's that?
Teach them how to prioritize.
Yes, because we've seen that in anemia, right? Yes, because you want to use the energy you have with what's most important to you, and that's hard. That's really hard. Y'all have learned that is in concept mapping and all that. Prioritization is hard, isn't it? And it really is difficult, and that I'm sure it's really difficult for those patients that are the victims of that. So anyway, just think about that. Okay, the home maintenance is really goofed all up if you think you're okay. I'm up and I'm moving, and then all of a sudden, I'm just spent. I can't do anymore. So that fatigue and everything can rule your life sometimes just as much as that does, if not more so. So anyway, so it is more common in winter months when to have the diagnosis made. Eventually, like after fatigue and malaise and loss of appetite, weight loss, and muscle aches and weakness and some of those kind of things that gradually set in, at some point the joints are going to kick up there and cause joint pain. So if it's not used for a while, it can start getting warm and tender and stiff. And it may get that way even if you are using it, but if you aren't, they may just really freeze, and you may not be able to use them without having some kind of surgical intervention or something like that. And the thing about this is another distinction between osteo and RA is that it's symmetrical inflammation with marked pain and swelling in fingers, wrists, elbows, shoulders, hips, knees, ankles, toes, and neck. So that's a lot of joints, isn't it? Right, yes. If one knee's affected, the other knee's affected. Now in osteo, you have a lot of osteoarthritis in football players and athletes that have had injuries in whatever sport, but football has a lot of injuries like that, and so you do see a lot of former football players as they get older. You used to see them walking they can hardly move. Have you seen that? Have you noticed that? And I've noticed this guy that walks in the neighborhood that we walk in the mornings. He's there. He's up real early sometimes, but he just looks like he's having such a hard time with his knees. And then if you look at his hands, he's got. It's not distortions like RA. It's from injuries. I imagine from because he played football. He's a great big strapping guy, and he's probably about my age, and so you get around 60 and things start falling apart anyway. But he's had some of that stuff for a long time, and I could see that his joints were sort of distorted, and it have been probably ever since he got out of college. But anyway, that is a distinction. You can have just on one hand, you might have the arthritis in your fingers, from injuries, and use. It's degeneration because you used it so much, you just worn it out. You can have it in both sides, but just typically. The RA is going to affect both sides, so it will be symmetrical, and with osteo it could be one or the other. Okay, so you can have a remission most likely during the first year, and that's just a kind of a general statement. That's not what everybody's going to do, but it is more likely during your first year of the diagnosis that you can have remissions, and then you can have a remission during pregnancy, and then there can be a relapse of the RA after the birth. So the pregnancy kind of protects you from that inflammation somehow or other, all the different chemical changes that go on in the body. So that's pretty interesting, isn't it? Did y'all talk about that at all? Y'all probably don't talk about that in the OB stuff, do you? Because that's for this week, isn't it? But Okay. So, additional symptoms. And this is another thing. We talked about anemia of chronic disease, and anemia of chronic inflammation is what they're calling it now. But that really does make more sense. Those inflammatory substances that are always in your system, that can decrease the production of red blood cells. And so the anemia of chronic inflammation instead of just disease is really a little more specific. I read that in an article fairly recently, and you're still going to see anemia of chronic disease. You see that in the Khan Academy videos. But anyway, the bone marrow doesn't produce enough red blood cells because of those inflammatory substances. So, it kind of varies from person to person on that. For some reason, the red blood cells are more susceptible, and I'm not really sure why that is. But yeah, you can have. I don't think that there is really a relationship with that. I don't know. That's a little further about that with the blood cells. And you can have burning and itching and discharge from your eyes because you've got all that inflammation going on in your body. Limited range of motion, of course. Sometimes you can have low-grade fever because of that inflammation. That's part of your the inflammatory process is that non-specific kind of attack on something that's foreign. And so the body's deciding that those immune complexes are foreign, and so you're just having continuous inflammation or the inflammatory response, and so you could have chronic low-grade fevers. You can have lung inflammation where you've got pleurisy or even effusion. Sometimes people can have the inflammation between the lining. The direct lining of the lung, and then the pleura when we've got that surfactant in between, and the surfactant can become inflamed, or in that area it can become inflamed, and so it can have like scraping, and that can cause the pleurisy, and that can be really, really, really painful for people, and it affect their respiratory function too. And nodules under the skin can be there, and they can they're subject to pressure in there, and that's a more severe disease. And sometimes those nodules can actually be so inflamed that they open up and get infected. And then you can have numbness and tingling because those inflamed areas can irritate the nerves as well. So, what's that? Oh, I keep hitting this thing. I'm sorry. Here we got all our wonderful pictures there. There we go. I fiddle with stuff too. I've got my pen, and I'll probably go flip. Okay. So it is resistant to iron therapy, and now I am not sure of all of that mechanism, but I noticed in one of those videos that I posted on Khan Academy during 112. That it did talk about how you can tell with certain blood tests and all which anemias will respond to iron therapy and which will not. But this not. So yeah, if y'all want to learn more about that, I know it is in the Khan Academy video. It's very complicated. So I listened to it, but I did not take it all in to memorize it. So I have to go back to that and see. But it is not going to respond to iron therapy. So you can have paleness if you can look sort of sick. You can have redness from the inflammation. And swollen glands even. Our lymph nodes can become swollen. And you can actually have destruction of the joints within 1 or 2 years after you're diagnosed with the disease in the severe cases. And muscle atrophy takes place because if you don't have the mobility of those joints, the muscles aren't being able to work like they're supposed to either. You can't move those joints, and the muscles don't move either. You've got those connecting areas on your bones, and they work together, and that's so the joints go, then the muscles go too. Okay, so nodules you can actually have rheumatoid nodules in your organs, like your heart and your lungs and your intestinal tract and the dura, the lining of the spinal cord and the spleen. So, and you can have vasculitis. So that's inflammation of what? So that's blood vessels. Yes, vasculitis. So that can be a big issue as well. Have any of y'all seen in your patients in clinical the C-reactive protein being elevated? Does anybody remember that? What that was for? Oh, I was good. You know that, don't you? What is that? Yes. So you don't know where the inflammation is, but you know there's definitely inflammation. So C-reactive protein is an indicator that there's been prolonged inflammation, and it's more predictive of potential cardiovascular effects, and it also can. Sometimes they look at the LDL for cardiovascular risk, but the C-reactive protein is even better predictor of cardiovascular issues. So inflammation is usually what causes our plaques to form, because you're getting inflammation on the lining of the vessels, and then the platelets and plaque, fat and stuff sticks to it, the bad cholesterol, the LDL. And then that causes the blockages and blood vessels around the heart, and that's how you can get MI and DVTs and all kinds of stuff. Okay. Let's see. Okay, you do have increased risk for low levels of the HDL and high cholesterol and high triglycerides, high blood pressure, and homocysteine is like that's an inflammatory hormone too, isn't that right, Julie? Doesn't it have a inflammatory relationship? Yeah, I'm pretty sure that homocysteine is but it is a increased risk of coronary heart disease if you have increased homocysteine or the increased C-reactive protein. So, you can actually have ischemic spots, and in older people, a lot of older people do have sort of brownish spots just on their legs. Now, it's not like those so much as the liver spots on your hands, but have you seen people like with sort of brownish down at their legs? And some of the people, especially men, it's pretty obvious that they don't grow hair on their legs as much as they did when they were younger, and so the absence of hair on the legs, and then those sort of brownish spots, that can mean that you're not having real good perfusion. So those are called ischemic spots, and so that they were brownish looking. And you can have them around your nail bed sometimes too, and they can actually ulcerate, and you can also have peripheral neuropathy because the nerves aren't getting the perfusion that they need to function either. So anyway, this is a systemic disease. Can you tell that? It's going taken care of. It's really depressing, isn't it, to hear all of these things that can happen. And we talked about the pleurisy, that inflammation in the lining of the lungs, but we can have that with our pericardium too, the lining of the heart. So that can lead to congestive heart failure. This is a big deal. That's why the life expectancy isn't so great. So a lot of medications that you use to treat RA can cause a whole lot of side effects, and some of those can be side effects on the coronary vessels. Just like we can't win the lose it. But okay, so let's get some of our ugly pictures for you. Have y'all taken care of anybody with really bad distortion like that? Some of y'all are probably in. So this is really terrible. I remember one little lady. I mean, she was just so curled up. She could not even pick up a spoon. She couldn't even have OT. Couldn't even help her because there was nothing. She just couldn't move her muscles or anything, and it was that bad. but she had a lot of those systemic effects too, and really couldn't do hardly anything for herself. It was really terrible. So, what's our ulna? Oh, you can see it right there, can't you? That's the outside one. And then we've got there's another one, the swan neck deformity. It's a little bit better picture, but they have this boutonniere deformity. But this is just like I don't know. It looks like something that they would put on a science fiction show or something that the aliens come. I mean, because that's absolutely not normal. That's not the way that our hands and feet are supposed to look. But that the ulnar deviation of the fingers, that means it's going towards that bone, because we know our radius is where we take the pulse, right? And the radial bone is that on the thumb side, but on the little finger side, if you can see that it's leaning, the fingers are leaning towards the ulna. And then subluxation, it can be like a dislocation, and then the MCP joints, and I always have to think about that one, metacarpophalange. That's what that is. Okay, so we got, our fingers are phalanges, right? And these are let's see, our wrist is our carpals, and these areas are the metacarpals, and this is the phalanges. So metacarpal phalangeal joints, and so that means it's these, right? There's knuckles. So, okay. And then our wrists and our elbows. The wrist is usually involved, and gosh, I hope y'all do get to come to the debrief about the RA and everything, or about the mobility, but Ms. Rumble can explain something. She's had loads and loads of surgeries. She ended up having to have a fusion. She had operations on her, like she had problems with the carpal tunnel and all that. But she's, I think it was right before Christmas. She wasn't teaching, and so she went ahead and had a fusion done. And she wears a brace on that almost all the time. I think she might just have to wear that forever. I haven't really talked in great detail about it, but she's had multiple surgeries on her feet and everything too. So she would be one to. She's a good reference person. She's a great teacher. Can't hurt it at all. She's a really good teacher, and Ms. Hyde is too. Okay, let's see here. So you'll get your carpal tunnel first, and then it could worsen into I guess. So our knees, you can have swelling and instability of the knees. You can have that. You can have instability with the osteo also if your bone is bone on bone. But the swelling is more common for the RA than it is osteo. In your ankles and feet, you can have the pain and the deformities, and the deformities are going to be somewhat like that. In the feet as well, it can happen. And hallux valgus is one of the, wish they wouldn't use Latin all the time, but it's the deviation of your great toe toward the other toes. But that's sort of like that ulnar, isn't it? It's just like you're going, they're turning out. The toes are turning out. So it's really just the same thing as the ulnar deviation, just on the foot. And let's see, you can actually have, my mom, and this is the funniest thing, because I had one of those cock-up toes where, I can't even think what you're supposed to call it. But anyway, it just kind of sticks up, and it's hard to wear certain shoes. It rubs a whole lot. So when I had my bunion surgery, I had the cock-up toe fixed too, and I can't even think what's the other word for that. This was actually in the book, cock-up toe. But I said that to my mom. I said I had surgery on my cock-up toe, and she just died laughing. I'm like, Mom, she's not usually into dirty jokes or anything, but boy, she just died laughing. I'm like, Mother. get your mind out of the gutter, whatever. But anyway, so I've got it in there. That came from the book. I didn't make that up. You know, I know that I did not make that up. So, and okay, in the sun, it's more likely to be in your cervical vertebrae. So, what do we need to look for if somebody's got trouble with their cervical vertebrae? Yeah, that can cause problems all the way down, couldn't it? Like to an arm or loss of range of motion of your arm, and you need to let the healthcare provider know if there's a change in the range of motion. And pain.
Affects their respiratory.
What's that? Oh, I bet so. Yeah, headaches, of course. Yeah. And then it can block the phrenic nerve. And the phrenic nerve governs our breathing, doesn't it? The movement of our diaphragm. And if that phrenic nerve gets pinched because of the abnormalities in the inflammation in the neck, it really could cause paralysis. Not just the paralysis of the legs and all that kind of thing, but it could paralyze the diaphragm, and that certainly would be a life-threatening situation. So this is very depressing. Lots of depressing stuff that goes on in the world. Good job, sunshiny smiles. We ought to at least give patients a break from thinking about all this kind of stuff. All right, rheumatoid arthritis affects joints symmetrically on both sides equally. They initially begin in a couple of joints only, and most frequently attack wrists, hands, elbows, shoulders, knees, and ankles. We already have that in our notes page. But the trick is, you can have osteoarthritis and rheumatoid arthritis at the same time, couldn't you? Yeah, and so it may be that one knee or whatever is worse than the other one because of wear and tear, and then you have RA too. So you just got to consider that they could be happening at the same time. All right, and then we got a normal joint with the joint capsule and the synovium and all of that, plates, the cartilage, and this is the joint affected by the rheumatoid arthritis. See how swollen that is compared to the one at the top. And you've got the inflamed synovium, that's that pannus, like the granulation tissue, which is a bad thing at this particular moment. So people can have it. We mentioned this a while ago, the rheumatoid factor. They can have high levels of circulating rheumatoid factor, which is antibodies against the joints. That's what that is. And then it's becoming a systemic disease instead of confined to the joints if you have a lot of that floating in if you have an abnormal level of that floating in your bloodstream. So that's telling you that it's advanced disease, the rheumatoid factor being positive. The immune complexes are the rheumatoid factor. That's a real high level. And it does behave like a type 3 immune complex mediated hypersensitivity. So stuff does kind of run together, doesn't it? Okay. So these are some nice normal fingers, and then you've got the rheumatoid arthritis in the late stages. This one is better swan neck. It looks more like a swan neck here, doesn't it? Instead of the other picture of what is obvious. But that root near deformity, you see how the thumbs kind of bend up and all. So you have that. You got that longer deviations when it's going toward the outside, and that metacarpal phalange. That's what that is. Metacarpal phalange. That's where it deviates. So yeah, it's like when I was a little girl and you see pictures of witches and stuff. It's just so horrible to think about that, because that's a terrible thing. Okay. So you usually have to have treatment for your lifetime. medications, physical therapy, exercise, education, and maybe even surgery. Well, that's what the Rumbles had to do. And surgery can be corrected to some degree to be able to work on the carpal tunnel and to do like the fusions to make sure that they're not too weak. And range of motion and individualized exercise programs, and it needs to be directed by a physical therapist because they need to be sort of specialists in that so that they know how much that you can try to move joints and how much to push people, because you don't want them to stop moving altogether. You want them to move as much as they can and to be able to have some mobility and function. And some of the things that have y'all seen like the heating cold treatments that like you put your hands in like paraffin, warm paraffin. They have these machines that you can melt the paraffin wax and put your hands in there, and you have to make sure it's not too hot. Take the temperature of it and things, and then put it, take your hand out of that, and it sort of coats it, and it's a real soothing kind of thing for some people. And you can have the splints or the orthotic devices to align the joints or support the joints. And if you get diagnosed with the RA early, then you may be able to delay the joint destruction and get on some anti-inflammatories because prolonged inflammation is damaging. It definitely is. So let's see. Surgery is going to be the last resort as far as you can try medications and everything. But if you're in a situation where, like you got a pinched nerve with the carpal tunnel, you just got to take care of that sometimes if nothing else is working. Okay, now this has changed. Used to be called juvenile rheumatoid arthritis, JRA, and now they're referring to it. And I didn't compare. I think I'd already given away my other first edition of the Giddens book, but I think that they were still calling it JRA with that first edition. But the second edition definitely says juvenile idiopathic arthritis. So if any of y'all read about that, then it's definitely called JIA mostly now. So obviously it's a fairly new term for us. So the treatment is similar to that of adults, and remission can last for months, years, or a lifetime. I know one family had a daughter that she was like 16, she was in a wheelchair from her rheumatoid arthritis, and when she got into her 20s, she had a total remission, and I think she still is okay. And I don't know that, I haven't talked to them recently, but I'll ask her brother. He goes to my church, but I didn't talk to him. But anyway, they can. This is one where like that adult kind is not going to leave you unless we find a cure that we don't know about yet. But with the juvenile, it can go into permanent remission. So that's a great thing. All right, so these two particular words, these are the terms that they use, but as long as you know that you can have multiple joints, small joints in the hands, or that affects the knees and the ankles and the elbows. The pauci-articular is just affecting those three things, and the polyarticular means that there's 5 or more joints, and usually like the hands or the fingers. But pauci means there's not many, and poly means that there are many. So more than 5 joints. So that's you don't really, as long as you know that you can have it either way. You can have polyarticular or the fewer joints, it's the pauci-articular. And then the systemic is when you're having fever and arthritis in just almost all of your joints, the synovial joints, and then you can have a rash also, and you can also have these nodules on the internal organs. So that can be very, very, very serious. So we're going to have a decrease in mobility and swelling and pain, and all just very similar to an adult. But let's see, it's as often as females as males. But this is sort of equal. And this is the onset's usually before 17 years of age, or 17 and under. And the way that they diagnose it is that you're having persistent onset of the symptoms over 6 weeks with no other identifiable cause. So that means if you're going to be doing tests for other reasons for you to have those symptoms, and then if they rule out anything else, they call it the juvenile idiopathic arthritis. And we don't know why that happens, and it is autoimmune, like it is. Onset is very similar to what we said with the adults. And this monophasic, polycyclic, persistent, you don't have to memorize this, but just to let you know that there are different ways that it can present itself. And if it's monophasic, it just starts for a little limited time, and then it improves. And the remission can last for months, years, or the lifetime, like you have in the slide. And the polycyclic means that you have occurrences of remissions and exacerbations, and remissions and exacerbations. It can recur periodically. And then the persistent means it's just continuous, at least for your 6 to 6 months in duration. So they're calling that persistent. So I don't really care if you know those terms, but just know that it can come and then go away, and then, or it can come and go, or it can be continuous. So I wouldn't worry about trying to memorize those words necessarily. Just know what's going on. Okay, and one of the things is that you can have uveitis. We don't see that one a whole lot, do we? The middle layer of the eye. Haven't studied that anatomy in a long time, but that the child needs to have the eye exams at least every year, and maybe even more than that, but at least every year. And they can cause inflammation, but it could lead to blindness. So there's also interference with the normal growth and from the bone growth disturbances and contractures or effusions, and those growth plates and everything can be damaged if you've got all that inflammation in there. So that could be something that even if they have a permanent remission, they may have had some damage caused with the growth plates, and they might be as tall as they might have been if they hadn't had that. And use of corticosteroids can inhibit normal growth in children. So corticosteroids are what? What do they do?
Inhibit growth.
We're doing inflammation. Yeah, we're trying to get rid of the inflammation. That's one of the easiest ways to do it, isn't it? But it can stunt the growth too. So we've talked about corticosteroids a lot, but there's lots and lots and lots of potential side effects, aren't there, that we don't always mention at the time. Talk about the blood sugar, all that, but the growth is a big deal. So what we're going to do is try to. What do you think our biggest issue will be if we're seeing somebody in the hospital with an exacerbation?
Comfort.
Yeah, pain and comfort. Yes. There you go. Pain, reduced inflammation, slower stop the joint damage, improve well-being and ability to function. Like if you're in some pain, you can't function. And there's no cure for the adult onset, but then you want to relieve the manifestations, of course, which is the worst thing is the pain at that particular point, probably. And use interdisciplinary approach. What are some of the other disciplines that we want to use?
Physical therapy, occupational therapy.
Yeah, PT, OT. So, and then the balance and the rest, exercise, physical therapy, and medications, then balance is something hard to achieve, and just like we're talking about prioritizing things, that like what discipline Do you think people? I mean, I'm just asking this because I don't have the answer. Who should give the talk about how to prioritize and things like that?
Case manager, social worker,
Yeah.
therapist.
Yeah, the physical therapists and nurses. Nurses certainly can too. But I guess really in the interdisciplinary, if everybody's, especially if they have a care planning session for a person, and everybody's sort of on the same page, or they can look at it on the chart when they do their care planning, because all the other disciplines kind of participate in all of that too. You can see what the nurses are prioritizing and the other people are too, and what the doctors are saying on their progress notes, and that we all want to be on the same page to encourage that person to be as functional as they can be and to have to set the priorities and such. So, all right, what we're going to do for diagnostic tests, we talked about the rheumatoid factor, didn't we? So that's definitely one we look at. What's ESR? Yeah. So what does that determine?
Inflammation.
Yeah, and we already said C-reactive protein. I don't know if I have that on that one. The C-reactive protein certainly is one as well. And so if this causes anemia, what's another blood test that you would do? So you have to check and see what hemoglobin and all that's going on. So, and there's antibodies to citrulated peptide that accurately detects early RA. So if you're way advanced, it may not be a way of detection, but citrulated peptides. And then synovial fluid for inflammatory changes, the turbidity and decreased viscosity and increased protein and WBC levels in, like Julia, we were talking about the WBCs, but there are going to be more WBCs in the synovial fluid. That's going to be a marker there of what's going on, and especially the X-rays of the affected joints just to see how much they're damaged. And especially if there's problems with the neck, if there's neck pain and inflammation, then a CT of the cervical spine may be a really good idea, or an MRI, just to make sure that it's not closing in on the phrenic nerve. And because if you have an injury and you're real vulnerable there on the neck, that could really be bad news. Have to be real gentle. They'll probably have to wear a neck brace a lot of times to protect themselves. And that synovial fluid, how would you get the synovial fluid? Yeah, the long nails. Anybody had that taken before? So yeah, you pull it out with a big long needle. Okay. So our criteria for RA have to have 4 of the symptoms, or these 7 symptoms. The morning stiffness, it lasts for at least an hour for about 6 weeks, and arthritis with swelling or effusion of 3 or more joints for at least 6 weeks, so the extra fluid production. Arthritis of the wrist, the metacarpophalangeal joints, and the proximal interphalangeal joint, the PIP, the PIP. So the proximal interphalangeal joint. So I'm thinking it's that, right? Is that right? The proximal interphalangeal joint, like that. Because the distal would be that one. So it has to be that, right? So that's the PIPs. So they got those all inflamed. Okay, and then the symmetric arthritis, that's definitely a sign. Rheumatoid nodules, and the positive serum rheumatoid factor, and the radiologic changes of RA in the hands and wrists that are characteristic. The radiologist would know about that. So. It really, since they're symmetrical, I would assume that it would be this joint on each side, and that would just be one. If it's in a, yeah. Okay.
Having to cover it on the garden last longer.
Okay.
Worse than it would have
It's
been.
like 9:31 on my phone. So let's do about a 10-minute break and we'll come back to our